Kia ora koutou katoa, and welcome again to Tamaki Makaurau for our update on the Omicron outbreak in the Northern Region. Thank you for joining us. I'm Andrew Old, the Chief Clinical Officer for the Northern Region Health Coordination Centre, and I'm joined again today by Dr. Anthony Jordan, our Associate Chief Clinical Officer and Clinical Lead for our Vaccination Program, together with Dr. Christine McIntosh, GP and Co-Clinical Lead for our Home Isolation Program, Whānau HQ. Today we continue with the same cautious optimism we talked about here last week. We will also take some time to focus on addressing some of the challenges our communities have told us they are facing with regards to managing this outbreak. My colleagues will discuss the changes to home isolation rules and how they affect those in our community. We will highlight the importance of vaccinations and clarify what this means if you've had COVID-19. And finally, we're going to provide a practical demonstration of rat testing for those who may be struggling to do theirs at home. But first, an update on today's numbers. Today we're reporting 20,989 new cases of COVID-19 across Aotearoa, with 7,172 of those here in Auckland. There are 856 people in hospital, 601 of those here in Auckland. 20 patients are in ICU, 10 here in Auckland. Sadly today we are also reporting a further 7 deaths, 5 in Auckland, 1 in Waikato and 1 in Southern. This is the highest number of daily deaths we've had in this outbreak. It highlights that although Omicron is a mild illness for many people, for some it is not. Every death is a tragedy, and our thoughts and condolences are with the families and loved ones of the people who have passed away. Now, I said last week we were cautiously optimistic that the virus might be close to reaching its peak here in Tamaki Makaurau, and 7 days on, I remain cautiously optimistic. Our 3-day rolling average of cases is about 8,500 per day, which is down from a peak of about 14,000. Although we know we're not detecting all the cases out there, we have good testing coverage of our population, with about 15% of everyone enrolled with a general practice having been tested in the past fortnight. And our daily test registrations remain high at about 30,000 per day. However, given the bumpy outbreaks we've seen overseas, it's certainly too early to call it definitively, but as I say, we remain cautiously optimistic. The average age of people in our hospitals is still relatively young, at about 40 years old, but as our total hospitalisations have risen over the past week, we are seeing more older and more vulnerable members of our community now impacted. This is a trend that was also seen overseas as Omicron continued to spread. What we've also seen overseas is that Omicron outbreaks have tended to have quite a long tail, with those older, more vulnerable populations tending to be affected towards the end of outbreaks. This is a timely reminder that although overall case numbers might be starting to plateau or decrease, people need to remain vigilant to protect those in our families and communities who are at greater risk. This includes elderly whānau and those with underlying health conditions. Another reason to remain vigilant is the issue of long COVID, which I just wanted to touch on as it's been getting quite a lot of attention this week. Although much of what we know about long COVID is based on earlier variants, what we do know should make us cautious. I would remind you that getting COVID is not inevitable, so please keep up the amazing work you've all been doing around mask use and good hygiene, as it will make a real difference as we start to come out the other end of this outbreak and beyond. As we explained last Friday, we were expecting hospitalisations to increase this week, and they have. As a percentage of current active cases, however, this remains about 0.5% of all current patients are in hospital, or current cases are in hospital. And if you look across the whole outbreak, about 1.5% of cases have now been treated in hospital. Now that's likely to be an overestimate, as we know we're not counting all infections. High hospitalisations and presentations are continuing to put pressure on our emergency departments and other inpatient services across the city at a time when they too are experiencing staff shortages due to COVID. We've been hearing from all of our hospital leaders this week about the incredible lengths their teams are going to in order to ensure that they continue to deliver the highest possible levels of care and services. For example, at Counties Manukau DHB, we have public health nurses who've stepped up to help in hospital roles at Middlemore. Allied health clinicians have provided assistance to orderly teams and covered healthcare assistants. Elective surgical staff have been redeployed from satellite units into acute services, and registered nurses and healthcare assistants, as well as on-call staff, have picked up shifts outside their normal hours to fill gaps in rosters. At Waitemata DHB, the entire legal team has been redeployed to support the security guards, and the Chief Financial Officer has even been seen working the wards delivering patient meals. At Auckland Hospital, anaesthetists have been working as phlebotomists taking blood, and the executive leadership team has been working in the emergency department, making beds, answering call bells and clearing linen skips. The Auckland legal team has also been deployed onto wards and is helping direct patients and whānau around the hospitals. These are just some of the examples in the way that our teams are pulling together to redeploy and allow our stretched clinical teams to provide the things that only they can provide. As I said, the situation in our hospitals with pressure from patients with COVID combined with high staff absences due to COVID is unprecedented, certainly in my career. It's thanks to the awesome dedication and flexibility of our staff that we are continuing to provide safe, urgent care for everyone who needs it. We are very fortunate to be facing this outbreak with such high vaccination rates, which is helping to keep hospitalisations down, but this is an area we need continued focus on. So with that in mind, I will now hand over to Dr. Anthony Jordan, an immunologist and clinical director of our vaccinations program in the Northern region.
Thanks, Andrew. There are a number of points that I'm really keen to clarify today around vaccination, particularly for those who have had COVID-19. As Andrew has said, we are fortunate to be in the position that we are with such high vaccination and booster rates. This has meant that a lot of people have been able to avoid coming to hospital and manage their illness at home. As I said last week, we always wish that our booster numbers were higher by the time we entered our Omicron outbreak, but my message is today for those that have not yet had their booster to make sure that you still get out there and get that done. In terms of wait times, there's been some need to clarify the timing of your dose if you've had COVID-19. The current advice is to wait 3 months for your booster, and actually that has some immunological sense to it. Once you've had an infection, you would expect some longevity in your immune response. So there are people that maybe not had a dose or dose 1, and they may choose to come earlier, like at 4 weeks, and we're happy to be able to provide that for them. For children, however, we recommend waiting 3 months before getting the first or second dose. We acknowledge that this wait time has been challenging for those, especially people affected by mandates and haven't had a chance to get their booster yet. It's important to note that exemptions are available for critical workers, and these are currently taking about 5 days to process, so we would encourage anyone who finds themselves in that position to make an application as soon as possible. While you may have built up some immunity by getting the virus, the extra booster will definitely help build further protection against reinfection or passing the virus on to others. We need to remember what we said earlier about the expected long tail of this virus. It's best to get the longest duration of protection we can from our vaccinations. This week also marks 8 weeks since our 5 to 11-year-old tamariki vaccination program began, so it's therefore time for people to get out and get their second doses for those 5 to 11-year-olds. Again, if your child has had COVID-19 over this period, you should wait another 12 weeks before going to get that next dose. There is a very low probability of reinfection over this initial period, and the second dose is still important to maintain protection long term. Just to give you a snapshot, boosters and 5 to 11-year-old vaccinations are still progressing well across the region. We have currently delivered more than 835,000 booster doses and just over 99,000 paediatric doses to date. Naturally, you're all aware that we have seen a slowdown in the vaccination rate across both of these areas, partly because people are dealing with COVID and having to isolate at home. That doesn't mean our drive for vaccinations has slowed down. We continue to extend our outreach program into high-risk areas, and over the weekend we'll see events in Mangere, Manurewa, Otara, Henderson, Waimaoku and Point England. My message today is simple. If you and your whānau are due a vaccination, then please do head out and get one. It will really help us to manage the long tail of the Omicron virus. Now I want to hand over to Dr. Christine McIntosh to talk more about what her and her primary care colleagues are seeing from home isolation services at the moment.
Thank you, Anthony. I wanted to start by reiterating Andrew's earlier comments about the incredible efforts of those people across our health sector in Auckland who are supporting the effort to support people with Omicron at the moment. As we're experiencing the peak of this outbreak, the whole system is feeling the strain and trying to manage patients' needs at the same time as managing the loss of their own staff for periods, and while they're also managing things that are going on in their own households as well. So they may have, be experiencing COVID themselves or have others at home. I particularly want to acknowledge all of those in the primary care sector who are really putting in incredibly long hours at the moment because they are really dedicated to keeping their communities safe. We know it's pretty tough out there, and we know that you're doing a phenomenal job, and we're seeing that because we're seeing with this outbreak that actually we are seeing lower hospitalisations. And I just really want to recognise that it is the work of all of the health sector that's really contributing at the moment, not just in Auckland but right across Aotearoa. The message from the sector is still very much about ensuring people are getting the help when it's needed and where it's needed. As we've said, most people are doing a great job of managing their illness at home, and many people are now starting to get comfortable with the idea that actually most people will be able to manage their illness very well at home. But we do want to stress that if you do need help, it's really important that you reach out if your symptoms are getting worse. Your GP or Healthline are there to help you if you need it. If things are really getting severe, please call 111 without delay. We know that there are pressures on the system, but we'd rather help you manage worsening illness at the earlier stages and then wait until somebody is really dangerously ill. On home isolation, we know that many people will have questions following the government's announcement on Wednesday about the change in isolation period from 10 days to 7 days. The Unite Against COVID website will be updated with the information overnight. We are at that stage of the Omicron outbreak that a change in isolation period is appropriate and will be appreciated by many households who are isolating in the community. However, if you are still feeling unwell at 7 days, it is important that you do still stay home until you are feeling well. And if you are feeling worse and not getting better, it's really important, as I say, to reach out and get the help that you need. I think we've had a lot of questions from people about what happens if I'm currently isolating after midnight tonight, and it's just really important to say that the 7-day isolation rules do apply to you too. Finally, I just want to add, like the rest of the sector, our Whānau HQ home isolation teams, that's our COVID care in the community here in Auckland, and our primary care partners are working extremely hard to manage a large number of people with COVID-19 and their households who are in isolation across Tamaki Makaurau, and I want to thank them for their incredible efforts. It's really important to note, and some people will have noticed as well, that the focus is particularly on people who are at the highest risk of more severe COVID, or those identified as having the greatest needs of support. In the Auckland region, we've developed a COVID triage tool which helps to sort the large number of new cases that are occurring in our community each day. And we are using that to ensure that we're able to focus our efforts on those people who are at the highest risk of more severe COVID. And as a collective, we work together to contact and support these people as needed. I want to stress that we are not able to call absolutely every single family in isolation. The focus remains on those who need it most. But as I said earlier, please do reach out for that support, either from your GP or Healthline if you are struggling at home, and they will do what they can to support you. On that note, I'll hand back to Andrew.
Thank you, Christine. Before we go to questions, I want to just provide a quick update on testing. So rapid antigen tests are now readily available right across the city. Since the 1st of March, we have distributed more than 2 million rapid antigen tests through our community testing centre sites and our rapid antigen test collection sites alone. In that time, we've also recorded now over 500,000 RAT results, 214,000 of those in the past 7 days. The positivity rates of those tests range from 28% for supervised tests at general practice up to about 46% for self-reported samples, which reflects the smaller proportion of negative test results that are being self-reported. We are delighted that so many people are taking up the opportunity to manage their testing at home. However, we are hearing that many people are still uncertain as to whether they have done the test correctly, so we thought we'd take this opportunity to bring along an expert to do a live presentation in the hope that it will clear up some of these concerns. There was a little bit of arm twisting required in terms of who was going to take one for the team here, so I'm very pleased to introduce Sue French, who's one of our nurse leaders and has been involved in the testing response right from the beginning and is definitely our resident expert on how to do a swab properly. Over to you, Sue.
Kia ora, my name's Sue French and I'm a nurse with the Northern Region Health Coordination Centre, and I've been asked to do a live demonstration on how to do a rapid antigen test on yourself. I am today going to be using the Orient Gene pack, which comes with 5 tests in each pack. You may have seen something different. There are many different packs around the country, and it's just important that you read the instructions that come with your kit. In each kit, it will contain a swab. The swabs can come in different lengths. Don't be alarmed if you get a shorter one. You'll also get in the kit a vial which has some solution in it, which is what your swab will go into. On this particular kit, on the back of the box, there's a hole that you can punch through, and that allows you to stand your kit up while you're doing things. There's a lid that needs to go onto this vial of solution once you've taken the swab and you've put it into the solution. Also in the pack, there'll be a foil pack that contains the cartridge with your test in it. And when you open it and drop that out, you'll see that the cartridge has 2 windows in it. There's a small circular window here, which is what you're going to put your solution into, and then there's a result window, and that may have a longer window which has 3 lines, or it could have 2. So it's really important to read the instructions in the kit that you have. This needs to go on a flat clean surface, and it stays on a flat clean surface until you've read the result. Each kit will contain instructions, and it is really important to read these, as each particular type of pack may have some minor variations as to how to do the test. I've also got a tissue with me that I'll blow my nose before I do the test, and I've already just done this, so I won't do it for the purposes of the demonstration. But it is important to blow your nose just to get those secretions in the front of your nose out before you do the test. I've cleaned my hands, I've got a clean surface, and I've got everything ready in front of me. The last thing I need is some way of timing the test process. So I've set my timer ready for the functions that I need to do for this particular test. So I've got my vial with fluid ready to go, the lid and the kit, and I've read my instructions. I'm opening the pack. When we're putting the swab into our nose, it goes approximately 2 to 3 centimetres into your nose. If you're not quite sure how far that is, that's around about to the first knuckle joint on your little finger for most people. But it's worthwhile measuring it so that you know. This swab needs to go in. I'm going to turn slightly so you can see the angle of approach. And it goes into your nostril at a flat angle like this. Shouldn't feel any resistance. It just goes in 2 to 3 centimetres. Then you're going to take the swab and you're going to rotate it 5 times, nice and slowly, to get cells and secretions from inside your nose. You're going to take it out, and then you're going to do the other one exactly the same. If you're not quite sure about the 2 to 3 centimetres, it's roughly around that, feels like a bony bit on your nose. 5 times, around and out. I'm going to take my vial of solution, take the silver lid off, and I'm going to put this in here. I'm going to rotate it, this particular kit, 6 times is what the instructions tell me to do. And then it asks me to put this down and to set my timer for 1 minute to leave that in the solution. For the purposes of the demonstration, we've already done this, so we're not going to do that for 1 whole minute. But it's really important, again, to read those instructions for what you're doing. I'm going to squeeze the vial, and I'm going to take the swab out, extract it out through the solution, pop it back in the kit, and put the lid on. Some lids will click, others don't. Giving it a flick to mix the solution. I'm going to turn it completely upside down so the solution's down in the bottom of the dropper. This kit requires me to use 4 drops in the well at the bottom. I'm going to keep that in case I need to repeat it, in case it's an invalid result. I'm now going to set my timer to 15 minutes, and I'm going to wait. So I've put 4 drops and I'm waiting 15 minutes. And what we'll see on the kit is that the solution, the window in here starts to change colour as the fluid starts to move across the membrane. At 15 minutes, you're able to read your results. Some kits require 10, some tests take 20. It's really important that you read it at the time that it's required. It'll tell you in the instructions not to read it after so much time because the result becomes invalid. I have done a test before, so here's one I prepared earlier. It's really, really important that this stays on the table, that we don't lift it, because the fluid has to cross over the membrane, and it can't do that if you're holding it upright trying to read it. So it's really important to leave it on the table for the full time. So this test kit, this particular test tells me I've got 1 line in the C area, the control, that tells me that I have not detected the virus. If I had 2 lines in here, there'd be a line across the T that would tell me that it has detected the virus. And this is a positive result, and one that we would need to record. We record all results, but this is the one that we're hoping we don't get. So 2 lines. Some test kits might have 3 lines. If there's a 3rd line, it's telling you it's invalid. In the instructions, it'll tell you what to look for if it's invalid, but mostly if you don't ever get anything across the C, it's telling you this result is invalid. You grab another kit out and do the test again. It may be something to do with this cartridge. Okay. Thank you.
Thank you, Sue. Cool as a cucumber. Something we mentioned last week, but I want to emphasise again, is the importance of recording your result. It's particularly important to record positive results at mycovidrecord.nz. Recording a positive result means your GP and our Whānau HQ system is aware and can assess your risk, as Christine mentioned, and provide any necessary support or care you might need. It is also important to register negative test results if you can, as that helps us understand how well the community is accessing testing. Finally, I want to repeat the thank you from last week to staff across the system who are working tirelessly to support this response, often well outside their traditional roles, as you heard some examples earlier. Thank you all. So we hope that's been helpful in answering some of the questions that we've been hearing across our communities, and we're now happy to open it up and take some other questions. So. Yeah, look, so the question was about people wanting to just catch COVID and get it over with. And actually, I'm going to answer that with an anecdote, because we've got a colleague at work who thought that very thing and then ended up in bed for about 3 days with his COVID. So I think the point I would make is that COVID is a mild illness for most people, but it is a more serious illness for some people and a very severe illness for others. And it's not just about you, it's about the people around you, that if you are sick with COVID and you don't know it, that you might pass it on to. So that might be an elderly relative, that might be someone immunocompromised that you bump into at a restaurant. And as I did mention, there is the unknown at the moment about long COVID. So although Omicron is an acute illness for most people, is milder, we really don't know much about what long COVID for Omicron looks like. What we do know about long COVID is from other variants, and there are some things in that should give us all pause in terms of some of the potential long-term effects.
I've got some questions regarding hospitalisations. I don't know if that's you or Dr. Gordon, either or is fine. But we heard yesterday that hospitalisations are higher than expected. It's only been 24 hours, but how have you been able to work out yet how many people are hospitalised for COVID as opposed to with COVID? Any better idea?
Look, so the question was about people hospitalised with COVID versus for COVID and sort of what hospitalisations are doing. And I wish I could answer the second part of that, the question about with or for better. I think the point I would make is that at a system level it is very hard to know, because we rely on looking at effectively aggregated data sources that tell us about who's in hospital at any one time. And as you will know, COVID presents in a lot of different ways. And so for individual treating clinicians in our hospitals, they will have quite a good idea whether somebody is in hospital with or for COVID. But from a system perspective, we often won't know that until sometime after they're discharged, because it involves individual notes review of those patients and looking at all of the other things that might have been going on in that admission and making a determination about how much of this was due to COVID and how much of it was due to other things. So don't have a good answer to that, unfortunately. But in terms of the numbers, again, I'm going to use the cautious optimism line. Today in Auckland was the first time since this started that we had fewer people in hospital with COVID at 8 o'clock this morning than we did yesterday. So again, one day is not a trend, but certainly that is the first time that we've had fewer people in hospital at 8 o'clock in the morning compared to the day before.
We've talked about sort of that lag time between case numbers and hospitalisations. So optimistically you're looking at peaking cases. Have we reached the point where we might be peaking hospitalisations-wise?
I am cautiously optimistic that we might be. Our cases over the last week have been consistently lower than they were the week prior, so that's good. And hospitalisations, as you say, do tend to lag by 7 to 10 days. So the fact that today we had fewer patients than we did yesterday is certainly a very encouraging sign, and that is borne out by what some of our clinical teams are telling us on the ground. We know at Counties Manukau, for example, the number of people coming through the door of the emergency department who are positive for COVID is lower now than it has been last week. So too early to call it, but certainly some encouraging signs.
In terms of reaching our peak, how are we supposed, what specific metrics are we using, or are you guys looking at to say this is where we're playing our peak, considering the amount of cases that we aren't being registered through the system? How are we able to say that?
Yeah, it's a good question, which is around how can we say that we're reaching the peak when we don't know about so many cases. I think the thing I would say is that we are consistently inconsistent, if that makes sense. So the patterns that we're seeing of the numbers of tests that are being registered, the positivity of those tests, the proportion of the population who are registering tests, would give us some indication that we are testing a similar amount effectively, and we're seeing fewer cases as a result of that. So although we don't have a really good sense of the total number of infections out there, we do know that, as I say, that our testing seems to be consistent, so we would be cautiously optimistic that the numbers of cases that we're seeing does represent sort of a true flattening. I would just go back to the cautionary note I made earlier, though, that while we're certainly down from the peak of last week, we think some of that initial peak was the switch to rapid antigen tests and quite an explosion of testing. And we have seen overseas some sort of bumpy peaks. So as I say, cautiously optimistic, but we're not out of the woods yet.
So just a couple of follows on that. What are we expecting? So you said those bumpy peaks. What would we expect based on those experiences, say, in the coming couple of weeks? And also, what's our estimated population gaps here in Auckland that we're able to speak to who aren't either registering their tests or aren't getting tested? Do we have some estimations on the population?
So we do have some of those estimations. I don't have the detail with me, but I'm happy to follow up afterwards. I think in terms of what we are predicting, or what we're hopefully predicting, is we would hope that our trend of fewer cases day by day does continue to step down. As I say, that's what we're hoping for, but we're certainly prepared for the fact that actually that might not be the case, and this might be a temporary lull. So all of this, let's say, hindsight's 20/20. So I'll be able to answer that question with 100% certainty in a few weeks' time.
We're still seeing reports of people doing rat tests and testing negative, but still going to work while infectious. Are we going to see potentially an increase in hospitalisation of rat tests as a result?
Sorry, I don't. So the question was people who have negative rat tests but go to work.
So they're reading their rat tests incorrectly, but they're still going to work while infectious. So is it going to be an increase potentially in hospitalisation of rat tests to make sure that they're coming through?
Look, I can't speak to the specifics of that example, but what I would say is we are operating now in a high trust model, so we do rely on everybody who takes a test to do so in good faith and to act on the results. Part of the reason for getting Sue to do a demonstration is we know that self-testing is not, it's not the most straightforward thing in the world. We are confident that most people can do it, but I would say if you're not confident doing it yourself, then we do have options for supervised tests, either through general, mostly through general practice, and we still have the option of PCR tests as well.
You spoke about all the DHB staff marking out. Do you have the numbers around how many DHB staff are sick or isolated at the moment across the
Look, I can't give you a specific number. What I would say is that things are very stretched right now across the DHBs, and services are literally managing on a day-to-day, shift-to-shift, and hour-to-hour basis in some cases. So giving you a sort of a number at any point is not particularly, it's impossible for me to do, but very challenging to do because it's really being managed. It's being managed at a very local level.
Is it possible to paint a bit of a ballpark figure about which departments or any insight into what the stretch looks like?
Look, I think probably not specifically, because genuinely it is everywhere. We're certainly seeing a lot of pressure at our front doors, so emergency departments, because that's where initial people sort of do come in. We are seeing we've got pressure in maternity, but generally pressure across the board at the moment, and the teams are doing an incredible job to be flexible and work off and outside their areas and in different parts of the organisations.
What's the flow-on impact of that? We've got members of hospital staff going outside their job description to look at COVID. Have we got some reviews or some reports into how that's impacting perhaps the legal side of the actual work or the other side?
Yeah, so the question's about what's the impact of people being moved out of other roles on the overall system. And we spoke last week about how much of our business as usual care, sort of planned and elective care, and other sort of non-critical things are being deferred. So I would say that we are in a crunch at the moment. So a lot of our services are operating at sort of what's called minimum service delivery. So a lot of those sort of more routine corporate type activities are being put on hold so that people can come and help out. If you think of it like those parts of the system are on pause, if you like, at the moment while we're in this hopefully sort of a 2 to 4 week period where things are tight, and then those are non-critical things or non-time critical things that can be picked up and taken forward, after that period. So I'm going to go over here.
Well, just to follow on.
Okay, I'm going to. So there's a question about general practice staff absences, which I'm going to pass over to Christine.
Thank you. So your question was about staff absences across primary care. So we have quite a large, extensive amount of primary care across the Auckland region. And yes, indeed, we are hearing that there are pressures, certainly within some practices, both by the number of cases that are occurring in their neighbourhoods that they're caring for, but also because of the pressures on their own staff from staff sickness. It's really important to state that we do have, we meet with the primary healthcare organisation leads every day, and we talk about those issues, and we have primary care resilience tool that primary care use to indicate where their pressures are. We also are really actively working with primary care to do whatever we can to support them, and giving them the tools that that they can use to help to manage the load wherever possible. But indeed, it is pretty stretched, and it is, the crunch is on, as Andrew says, in the system. No, I haven't had those reports. No, I have not had that feedback. No, I do not have that information. Yes, I think that people will be very concerned about that. The normal things that we do as business as usual in primary care are all very important. But as in the hospital system, practices at an individual level are making choices about what it is that they need to prioritise at this point in time. And so I would say that they are enabled to make those own decisions for themselves about what is the priority at this point in time. And just for doubling back to that previous question about staff absences and so forth, so while I don't have the information to hand, I will be able to get that information if you require it.
Just on people passing away with COVID, obviously we've seen, I think it's 100% have passed away in hospital, home yet. Are you expecting any people to pass away at home while they're isolating with COVID?
So like Andrew and Anthony have been talking about, and I certainly reinforce, Omicron for most people is a mild illness, but for some people it is a more severe illness, and for some people it's a very serious illness. And obviously the success of a Whānau HQ COVID care in the community program is that we're supporting everybody in the community, and when they do need to go to hospital, they get there and they get the treatment that they need. So, what we're trying to aim for with our COVID care in the community is actually really to avoid deaths in the community and avoid deaths overall and support those people who most need it.
Yes, certainly, that's the hope, but is there an expectation, is there a prediction? There will be reports on this as to whether there was an expectation that some figure of people, a number of people would die in the home. Is there a number?
There's not a specific number, no. We are very focused on our goal of making sure that people get the care that they need and the place that they need it.
Yeah, so the question was about how quickly do people potentially become reinfected, and a question about complacency with that. So one of the changes that's coming in tonight is around the shift from when you have been a case to when you sort of need to worry about being a case again, moving from 28 days out to 90 days. And that's based on evidence from overseas that shows that the chances of being reinfected with Omicron within about a 3-month window are relatively low, not zero, but relatively low. So that's the sort of time frame that we're talking about. I would say though that all of the measures that are in place that protect us from Omicron are the same measures that protect us from a range of other respiratory illnesses, and it's probably quite a good time to note that with borders opening, we are likely to see an increase in other illnesses that we have not seen for some time. So I'm particularly thinking, as we head towards winter, of influenza and also RSV, which is particularly an issue for children. So I think the message at the moment would be keep keep up with those hygiene, masking, infection prevention and control things for as long as you can. Yes.
Isolation times reduced to 8. Are you concerned that that will mean case numbers once again rise?
So the question was about with the reduction in the isolation time, what that might do to case numbers. I think the reduction in the case isolation time from 10 to 7 days is based on evidence from overseas that suggests that actually a relatively small proportion of people who have COVID will still be infectious at 7 days. Now, like a lot of this, it's not zero, but where this is a risk balance exercise, and so no, we are confident that the reduction from 10 to 7 days is not going to see a significant increase in cases. Indeed, if that was what we were expecting, then that change wouldn't have been made. So. So I wish I had a crystal ball, and I wish I could forecast what winter was going to look like. We are starting to see overseas some signs of follow-on increases in Omicron cases, particularly seeing that in the UK and starting again now a little bit in Australia. So I think that sort of reinforces the answer to the previous one of the previous questions as well, that everything that we can do to help minimise the spread of respiratory illness through use of masks, distancing, hygiene, those sorts of things is going to be really important. We expect that winter's going to be tough. We know that we're likely to have influenza, as I mentioned, RSV and other things, and it is possible that we will also be dealing with some more COVID at that time as well. So unfortunately, a lot of that is crystal ball gazing at this stage, but we're certainly preparing for that possibility.
Clarify those dates around when you go to the post-infection. So if I'm an adult, if I'm a kid, can you lay that as basically...
Sure. So if you have COVID and you're 5 to 11-year-old, we recommend you wait 3 months. If you're an adult, we recommend that you wait 3 months as well, but there'll be some people in there that will want to get, if they've had no doses, or one dose, that dose brought forward and having it earlier, and so we do allow people to have it after 4 weeks. But again, just to think about the other question that came before, is if we can get as much protection from vaccination over the winter period, that would be a good thing to put in place to reduce numbers of illness coming in over that time. So that's some of the recommendation about why we want to lengthen that out to get as much mileage out of vaccination as possible. There isn't really a risk, it's really about mileage out of the vaccination. So again, we want to be convenient and accessible to people. We want people to be able to return to work if there's a mandate requirement for vaccination. So all of that stuff is taken into consideration. So we need to be eminently flexible. Cool. Thank you, Vaughn.